Hello, and welcome to this Hospice News webinar on documenting for relatedness, better care through compliance. Hospice providers often encounter difficulties when it comes to documenting which services are directly related to the patient's terminal diagnosis as opposed to a comorbidity. Today's program, which is sponsored by Axxess, will provide strategies for providers on how to navigate those complexities. My name is Jim Parker. I'm editor of Hospice News. And with me is our speaker, Carol Javens, Implementation Manager for Axxess Hospice. Carol helps new clients transition onto Axxess software, ensuring that they learn the platform and utilize its full functionality. She has extensive experience as a hospice nurse, including certification in hospice and palliative nursing. She has a passion for hospice education and compliance. Following Carol's presentation, there will be a question and answer session. Listeners, feel free to submit questions using the designated window on the GoToWebinar app. Slides and a recording of the presentation will be made available after the webinar. So Carol, I will turn this over to you. Thank you very much for being here.
Thank you very much for having me, Jim. And again, I'm Carol Javens, and I'm going to be talking about documenting for relatedness. So today, the goals that we have for this presentation are that we're going to understand a little of the history of Medicare spending outside of the hospice benefit, how to determine and document diagnosis relatedness and subsequently unrelatedness, how to then determine and document the medication and treatment relatedness, and how to have some organizational processes in place to manage regulatory scrutiny. Now, when I say regulatory scrutiny, I do need to make sure you understand that this is not just with CMS, but this is also related to your ZPIC audits and your, any of your RAC audits. Your ZPICs are called by Medicare to look and see if there's any fraudulent billing practices, and your RAC audits are going to be possibly going to uncover some fraud, but often what they're also going to do is look for errors in your documentation that cause and trigger underpayments or overpayments. So those have been going on for years, but so this will also help you with being able to withstand that as well. So, but the big trigger of why everyone's talking more about relatedness right now is this addendum to the election statement that started with fiscal year 2021, which was last week. It's officially called the Patient Notification of Hospice Non-Covered Items, Services, and Drugs. Now, all Medicare patients admitted on or after October 1st, 2020 is who this applies to at this time. It's not all patients forever, and it's not non-Medicare patients at this time, although it could change at any point in the future. But right now, it's Medicare patients admitted on or after October 1st will have the option to request this election statement addendum explaining why the certain treatments and diagnoses are not covered under the hospice Medicare benefit. Now, not just the patient can ask for this, their legal representative can ask for it, a non-agency provider can ask for it, or your medical contractor can also request this addendum. And the hospice organization must provide this addendum if it's requested at admission within 5 days, and if it's requested after admission within 72 hours of the request. Now, there was recently last week a clarification by CMS about the 72 hours, where they said they're not actually counting the hours from the hour of admission, but what they meant was 3 days. However, the language they put in is 72 hours. So, but their clarification said it is 3 days. So understanding how we got here is looking at the history of the Medicare spending outside the hospice benefit. So back in 2012, the Office of Inspector General, or OIG, issued this report, and they have wonderfully clear titles for their reports. Medicare could be paying twice for prescription drugs for beneficiaries in hospice. So they suggested that CMS give a little more oversight into making sure that the per diem rate that's being paid to the hospices is covering all of the medications that it should, and we're not paying again for those same services through Medicare Part B. And the OIG identified almost 200,000 beneficiaries who received over almost 700,000 drugs through Medicare Part D that potentially should have been covered under the per diem payments. And the payments to that were, almost $34 million. And the beneficiaries paid almost $4 million in co-payments. So CMS disagreed in giving oversight, but they said that giving some more education to hospices and pharmacies would be important and they would take that up. And they also disputed the methodology used by the OIG to determine that amount of overpayments. They think the OIG overestimated what the actual amount was and the problem. So, after the 2012 OIG report, those of us who were working in hospice back then remember that we had this massive problem with documenting all of the medications that a patient needs to get under Part D that were not related but necessary medication. The paperwork burden was tremendous. The hospice physicians and the hospice providers were filling out form after form trying to get these medications for people that they needed. Patients sometimes went without these medications for long periods of time. And this lasted about a year because it just wasn't a sustainable process. So, however, the cost of Medicare Part D continued to rise even after this year. And there were also more studies showing that not just the Part D costs were rising, but the Part B, durable medical equipment and supply charges, were also increasing. Things like patients who were on COPD or CHF or lung cancer on hospice who had pre-existing oxygen that never got changed out and continued to be billed to Part B, and supplies that were being wound supplies and things like that being billed to Part B. So there was a lot of double spending in the OIG's opinion. And this slide from NHPCO showed that you see in fiscal year 2014, the cost did go down when we were having to fill out all those forms and patients were often going without any medications. And it bounced right back to a higher rate than ever before. So the numbers just keep going up and up for what Part D is spending for medications on patients who are currently on hospice. So last summer, there were two reports the OIG put out. One of them everyone is familiar with, I'm sure, that talked about possible fraud in admitting patients to hospice who were not eligible and potential fraudulent use of general inpatient and continuous home care. And the second report that came out at the same time was also titled very clearly Medicare Part D still paying millions for drugs already paid for under the Part A hospice benefit. So they were very transparent in all of their methodology. It was a very thorough report in response to CMS questioning their methodology on the 2012 report. And you can see that they're giving these numbers that in fiscal year 2017, it was $474.2 million in Medicare Part D drugs received by hospice beneficiaries. And the Medicare part was $380.5 million. And then there were co-pays as well that were being paid by the patients and families, where what the OIG was saying is that instead of Medicare Part D paying for some of these, the patients or the hospices should be paying for these medications. So, and after everything that OIG had put out in 2012 and all those processes to get approvals that didn't really pan out, the spending by Part D just kept going up and up and up. So CMS responded in this way in 2019, where they basically said that the Medicare hospice benefit requirements never really said that there's any difference between pre-existing chronic and controlled conditions. And we're going to come back to this next statement here, in that it is very telling what CMS is expecting from us is that everything is interrelated. They're saying, acute and chronic conditions, controlled and uncontrolled conditions are all part of determining a prognosis, and all body systems are interrelated, and all conditions have the potential to affect the total individual. So all of these comorbidities and secondary conditions need to be considered. And it looks like from in here, they're saying probably considered to be related. So now we have the fiscal year 2021 hospice final rule that came into effect last week with that patient notification of hospice non-covered items, services, and drugs. So we have to provide, as hospice providers, a written clinical explanation in a language that the beneficiary and his or her representative can understand as to why the identified conditions, items, services, and drugs are considered unrelated to the terminal illness and related conditions, and that why these are things are not needed for pain and symptom management, and provide references to any relevant clinical practice, policy, or coverage guidelines. So that's where we are now. In addition to the RAC and ZPIC audits that have been ongoing for a few years, we now have to provide this in writing in a very short period of time for Medicare patients that have been admitted after October 1st. So where do we start with coming up with these, what's covered and not covered is looking at the diagnosis relatedness. So how do we determine that, and how do we document both relatedness as well as unrelatedness, which is the bigger challenge, is determining the unrelatedness. So it always starts with finding what is your primary terminal diagnosis. So when you're talking to the hospice physician and attending physician, if there is one, coming up with what is the diagnosis that's most contributory to the terminal prognosis of the individual. A lot of people have multiple major medical issues going on, so looking for the primary one can be a little tricky, going through all of them and suggesting to the physician, what do you think is going to be the number one thing on this patient's death certificate? What is the primary thing that will cause them to have a life expectancy of 6 months or less? So we are supposed to review the relevant local coverage determinations, or LCDs. There's one for each Medicare administrative contractor. They are similar. NGS and CGS are a little more similar than Palmetto. Palmetto's is a little more vague, but all of them are listed as guidelines. They're not regulations, but they are guidelines that we need to take seriously. But ultimately, if the patient doesn't meet all of the criteria in the LCDs, they could still be eligible for hospice. And that's based on that physician certification narrative in the CTI, looking at all of the comorbidities, all of the secondary conditions, and the functional and structural impairments from the disease process. So this is where you'll maybe have your patient who has a primary diagnosis of Alzheimer's disease, but their FAST score is 6D perhaps, and they're not at 7 or beyond, but they've had 3 hospitalizations, and they're having multiple infections, and they're having skin breakdown, or all of these different secondary conditions that are listed in there. And then maybe they have a comorbidity of CHF and they're diabetic. So when you put all that together, that LCD requirement that the Alzheimer's patient needs to have a FAST score of 7A or beyond is only one part of the picture. And that's where it becomes the guideline and not the regulation. It's up to the hospice physician to put together the story, looking at the full picture of the patient as to what is the terminal diagnosis and that the patient is eligible for hospice services. So in looking at the secondary and comorbid conditions, diagnoses, and symptoms, getting as much history as possible at admission or as soon as possible after is key. And sometimes we admit patients urgently and we don't have time to get every single record because they're in symptom distress. But as soon as possible as you can, get the attending physician records, get the hospital discharge summary and history and physical. There's a lot of information in there. Nursing home records from our patients at nursing facilities, and also the comprehensive assessment from the IDG in those first 5 days. So to review, a secondary condition is something that is caused directly by the terminal diagnosis. So that would be something like dysphagia if you have a neurological condition, or pressure ulcers from immobility if your patient is having that. So, oh, excuse me, I skipped forward a little. Looking at your comorbidities is Medicare specifically mentions things like renal disease, liver disease, COPD, CHF, diabetes mellitus, HIV or AIDS, any history of cancers, um, lupus. They mention rheumatoid arthritis as specifically being significant comorbidities that impact a patient's terminal prognosis. So all of the secondary and comorbid conditions need to be documented in the patient record and submitted on claims regardless of relatedness. So this is part of fiscal year 2016, where they changed from just putting on one or two diagnoses to Medicare wanting every diagnosis to be submitted. And part of that was looking at, are we going to potentially have case mix like what PDGM has in home health right now, and looking at some different pictures of how this is all going to work. But all of the diagnoses are supposed to be listed. And the UB04, which is the claim type for Medicare, does allow for 25 diagnoses outside of the primary diagnosis. So the hospice organization, and specifically the primary hospice attending physician, needs to review each secondary and comorbid condition to determine, in it, no matter what your primary diagnosis is, if any of these conditions are contributing to the 6-month prognosis. No matter what your primary is CHF going to be helping make the prognosis decision? Is diabetes part of why you feel that this person is going to have 6 months or less? So other than your primary diagnosis and your secondaries and comorbids, there's conditions caused by or exacerbated by treatments of related conditions. So that would include your side effects from your medications. It would consider a deterioration of a previously stable condition with the patient's changing status. And that includes diagnoses, conditions, and symptoms. So some of the examples here are constipation from pain medication is something that we are supposed to be paying for because it's related to a treatment for what were the primary diagnosis. Blood sugar fluctuations in a diabetic who was previously diet controlled, maybe they were DM type 2, never took any meds, their sugars were fine, and now based on their declining condition, they get skin breakdown, they're getting infections, we've maybe put them on steroids for pain, and now these blood sugars are jumping all over the place. So the uncontrolled symptom of the diabetes is related to the treatment for the primary diagnosis. Looking at stomach irritation from medications, renal dysfunction from treatment of CHF, we've got to have someone on potentially large doses of furosemide and metolazone because they're in such big fluid overload and we're causing kidney issues because of their comfort medications. So then the kidney issues would be related to the primary prognosis of the patient. So to document your diagnosis relatedness, it is important to look at all related diagnoses, conditions, and symptoms and put those in the CTI narrative as contributing factors as to why the patient has a prognosis of 6 months or less. So, and what Medicare is looking for, and they've specifically stated, is unless there is clear evidence that a diagnosis is unrelated to the patient's terminal prognosis, they are considering it related. It is a very high burden of proof that hospices have to show that these secondary conditions and comorbidities and conditions are not related. So ultimately, it comes down to the hospice physician. Throughout all of these rules, it's saying the hospice physician is responsible for determining these relatedness. And relatedness determines the coverage of everything from that, your medications, your DME, your supplies, and your treatments. So if the diagnosis is related, then everything to treat that diagnosis also is related and should be covered under the hospice Medicare benefit. And everything that is related needs to be on the patient's plan of care. So if you're saying that your patient has a primary diagnosis of Alzheimer's with a significant comorbidity of CHF, you need to be monitoring your CHF in your plan of care because that will be contributing to the patient's decline and symptom burden and comfort ultimately. So documenting unrelatedness is the huge challenge for the hospices. So how are you going to figure out what is unrelated and how are you going to document that when CMS is basically saying in very clear words, everything is related unless you can prove otherwise. So the clear evidence needs to be documented. In the chart reviews I've done over the years, often what I see listed for the reason that something is unrelated is not related to the terminal illness, is what's written. And that's not going to cut it. The OIG specifically listed multiple occurrences in their most recent report where the hospice physician wrote in the certification of terminal illness narrative that a comorbidity was part of why the patient had a 6-month prognosis or less, and yet we didn't pay for the treatments related to that comorbidity. One example they gave was a patient who had a primary diagnosis listed in the CTI of Alzheimer's and a secondary condition documented of Parkinson's disease, but the Parkinson's medications were not covered because what the hospice organization told the OIG was that they didn't pay for medications that weren't to treat the primary terminal diagnosis, which is the opposite of what CMS is wanting to see because they're saying everything that's related is the responsibility of the hospice. Another example that they gave was diabetic treatment. When diabetes is listed as a significant comorbidity contributing to the terminal prognosis, but hospices were not paying for the strips, the syringes, the insulin, all of the things that go along with managing your diabetes. So looking at that documentation of the diagnosis and really looking at proving that it's unrelated is very challenging. And that is ultimately the responsibility of the hospice physician. It's very hard to do. So, what about mental health diagnoses and conditions? Well, the Federal Register mentions that for the fiscal year 2016 when they talked about including all of the diagnoses in the patient's record and claims. And they specifically said that they want reporting of any mental health disorders and conditions that would affect the plan of care, as hospices are to assess and provide care for identified psychosocial and emotional needs as well as for the physical and spiritual needs. So if you're care planning anxiety disorder or depression or schizophrenia or bipolar disorder as something that's impacting your patient's adjustment and psychosocial and spiritual needs in your hospice plan of care, then that would be something that would be considered related. Look for that care plan. If it's care planned, it's probably related. Now, for years, what I've seen in my practice, and you've probably seen in yours, is a patient might have anxiety or depression that predates their terminal illness by 20 years, and it's been managed, and they don't have any major issues with it. But as the patient's condition changes, that could change as well. So Medicare is expecting that when we're determining the diagnosis relatedness, that this is not just done at admission. It's done as an ongoing basis because something that might be considered unrelated to the terminal prognosis right now could become related to the terminal prognosis and impact the plan of care later. So that stable blood sugar on your diet controlled diabetic who has no secondary conditions, they don't have any retinopathy or neuropathies or any other issues that can happen from diabetes, might be fine. But then later when we start changing the treatments and their blood sugars start being goofy and unregulated, that it might now be something that's related. So the same will happen with your mental health diagnoses and conditions. That controlled anxiety and depression might become more of a challenge for the patient to manage and require more treatment interventions, changes in medications. So after saying all these things that I just said here, is everything related? I'm going back to that statement that CMS gave in response to the 2019 OIG report, and now I'm going to read it a little bit more slowly. We have recognized throughout the federal regulations that the total person is to be assessed, including acute and chronic conditions, as well as controlled and uncontrolled conditions, in determining an individual's terminal prognosis. All body systems are interrelated. All conditions, active or not, have the potential to affect the total individual. The presence of comorbidities is recognized as potentially contributing to the overall status of an individual and should be considered when determining the terminal prognosis. So that's that very high bar that we're going with, and that CMS is saying that they've always said this, although it hasn't always been an expectation that we are reporting all these things or care planning all these things. And for years, the focus was on what is the terminal diagnosis, and we cover and care plan for the terminal diagnosis, to switching to the terminal prognosis and everything interrelated. So, is everything related? It feels like, where we talk about the how to determine and document medication and treatment relatedness. So we start everywhere, of course, with the diagnoses and figuring out if this diagnosis is related or unrelated to the terminal prognosis. But then we have to go into the medication list and start with, is every medication that this patient is on needed for this patient? And the diagnosis might be related, but is the medication appropriate? So, doing a thorough medication review for potential adverse reactions, doing a risk versus benefit analysis of each medication, looking at drug interactions and polypharmacy. This has been a top 10 tag throughout the years, that medication reviews are not being done and documented. They might be done, but potentially not documented. So start there before we determine if we need to pay for it. Find out if we need this medication. One of the options that we can use for this is the Beers criteria medication list. Use the Beers criteria cautiously, though, in our hospice patients. For our patients who are higher functioning and more at the 6-month prognosis than 6-day prognosis, the Beers criteria can be much more relevant. However, anyone who's examined the Beers criteria sees that every single comfort medication that we use in hospice is listed on the Beers criteria as contraindicated for our geriatric population. So that's where the risk versus benefit analysis comes in, is that if your patient is ambulatory and more cognizant, and you put them on a anticholinergic to help with their secretions, and they become someone who's falling down, if they start having agitation or psychosis, which are things that can happen from anticholinergics, that's much more of a challenge and becomes more contraindicated than a person who were using anticholinergics in their last days to hours of life for terminal secretions. So the risk versus benefit analysis changes based on the patient's prognosis, and if we're talking about months, days, or hours of life to live. Have your pharmacist review these medications, especially if you have a contract with a pharmacy benefit manager or PBM. Get that pharmacy consult and see what are some of the things that we can be reducing or eliminating or changing for our patient to have them be as safe as possible, as well as cost effective as possible. And part of that, again, with the cost effective, is your hospice formulary. A lot of patients do not want to switch off of their medications to a formulary medication. The hospice medication formularies are research based, they're best practice, and they're policy. Those are things that are very important to document when you're saying you're not going to cover a medication. If a patient refuses to switch from a non formulary medication to a formulary medication, and you've had that discussion and education with them, that would be a reason, as long as it's documented clearly that you've done the education and they're refusing, for not covering the alternative, because you're offering them a therapeutic alternative that they are declining. One of the big things in geriatrics as well as in hospice is deprescribing. So, does your staff know how to have that conversation? It is a very challenging conversation to have, especially early on in the hospice process, where there's a lot of misconceptions from patients and families that hospice comes in and they take them off all their medications and just try and make them die. You've probably all heard that from someone before, when actually the research shows that deprescribing and looking at all of these risk versus benefits and adverse reactions and polypharmacy, by taking patients off of the right medications, they often feel much, much better. And but that's not how it's perceived by patients, and sometimes it's not how it's perceived by attending physicians either. And so it can be tricky to navigate that conversation, especially when a patient or family member may have been told by a prior physician that they have to take this medication for the rest of their life. So discussing stopping this medication is challenging, because people will hear that as, I'm dying tomorrow, which is not the case. So that can be tricky, and it does require a lot of training for your staff on how to navigate that potential minefield. Also, look at, is the medicine still indicated? And this is for your anti-Alzheimer's medication or your Alzheimer's slowing medications, as one example. When the patient is hospice appropriate for end stage Alzheimer's or potentially another disease where Alzheimer's is a comorbidity, the medications to slow the progression of Alzheimer's are indicated for mild to moderate Alzheimer's disease. If a patient is truly hospice appropriate, that medication isn't indicated anymore, and the risk versus benefit analysis would show that the benefit is very, very slow or low once you're at end stages of disease than when they originally started taking this medication. Another example of this might be some oral chemotherapy agents meant to slow the progression of cancer. Once they're on hospice, is that still an indication if you're truly hospice appropriate at that? So starting with, is the medication needed? And moving on to what medications should be covered. So CMS has very directly stated that virtually all medications and treatments are going to should be covered by the hospice Medicare benefit for the patient. They're assuming that unless you can prove otherwise, that you should be paying for these things. So I have usually in there for a reason, though, because every patient is individual. And we need to not have a completely cookie cutter determination for every patient with these diagnoses. These are the right and wrong medications. Generally speaking, we have these guidelines, but everyone is different in looking at their individual needs. So, what's usually covered, of course, is medications related to the terminal diagnosis, assuming the risk versus benefit analysis is showing that there is benefit to this. Medications for pain and symptom control, medications for conditions for the secondary diagnoses, for the comorbidities that are severe enough to affect the patient's prognosis. So if the physician's writing that in your CTI narrative as related to why this patient has a 6-month prognosis or less, those are medications that you need to be covering as well. Comorbidities that are physiologically related to or involving the same organ system as the primary diagnosis. So if you have a patient on for kidney disease and their type of kidney disease is hypertensive kidney disease, so Physiologically related medication would be your cardioactive, your cardiovascular medications, because your kidney disease is caused by your cardiovascular disease. The same with if you have three different cardiac diseases or cardiovascular. I have CHF, so we should pay for the hypertensive medications, and you should pay for the medications to relax my blood vessels, all of those things. So looking at those comorbidities that are related. And also, we should be covering any medication to treat side effects of your covered medications. So if you have somebody who's on dexamethasone and they're agitated and we need to help relax them a little, that would be something that's covered. Or if it's causing GI distress, or if you have someone on opiates and they're having constipation. And again, as the patient is on service and time passes, this can change. So, looking at what is related and not related, what medication should be covered and not be covered, is not a one time decision, because these medications, risk versus benefit analysis, can change as the patient declines. So then what medications are not usually covered? Again, usually. So we all know a lot of our hospice patients who are on supplements, they'll come to us on the multivitamin, the calcium, the iron, the 6 different supplements that are probably not effective at the end of life, but the families have an attachment to this medication giving some benefit. It's probably not giving benefit. It's also probably not harming. Probably. But if it is harming, I mean, it's increasing the pill burden. Iron has constipation as a side effect. Some of these can cause an upset stomach. So they're not necessarily harmless. So we should be looking at that as well. Experimental medications. If a patient is on a clinical trial, we are definitely not expected to pay for that. The pharmaceutical company would be expected to pay for that. Medications not indicated for the diagnosis or treatment of the illness. So that's where we go into your Aricept and Namenda for your end stage Alzheimer's patient. It's clinically not indicated at that stage of the disease progress. Medications not considered safe or effective. This is again where we're looking at our Beers list for safety. We're looking at interactions. If we're looking for a medication that's indicated to slow the progression of a disease that's already at the end stage disease. And also, this is the one that is really important to look at, is your medications related to conditions that do not affect the prognosis but are needed to maintain equilibrium. So your thyroid replacements, your hypertensive meds in a patient without any significant cardiac symptoms, your glaucoma medications. So, and then the documenting of those diagnoses that go along with that, your hypothyroid, your glaucoma, is very important to just say, not say again, not related, but to say hypothyroidism is not physiologically related to the patient's lung cancer and not contributing to their 6-month prognosis. Would be a way to document that the OIG would accept. Your glaucoma medications, you could document in the same way. Glaucoma is not physiologically related to the patient's Alzheimer's disease and does not contribute to their 6-month prognosis. So writing it in narratives like that will be very beneficial for you to withstand any regulatory scrutiny. But CMS has stated that they expect that any other healthcare professional who looks at the same data is going to come to the same conclusion after reviewing this patient's chart. So be consistent throughout the patient's chart in that you're documenting what you are not covering, what is and is not related, and also making sure that you are being consistent from patient to patient. In that, again, I said every patient is not the same. You do need to make individual clinical judgments, but sometimes we will pay for medications to treat the family, and because they're not willing to let it go, and we're not doing that for everyone, they could call back into question if we're really making these decisions based on clinical practice guidelines and policies. So be careful in also your cross-patient consistency as well. So you're documenting your rationale for non-covered medication, just like I'd said, relate it to a condition that's not related to the terminal prognosis and symptom burden. And if the patient or family won't switch to that formulary medication, it is very key to document the attempts to change it and the education that it would be provided at the family cost, not billed to Part D. So this is where part of the problem is the families somehow still get it covered under Part D when it should be covered by them. To protect yourself and to make sure that you have it in writing, consider using the ABN to document the discussion and notification. Remember that the ABN needs to be given prior to the medication or treatment or ambulance ride or ER trip happen and not after, because if it's given after, the hospice could still be potentially responsible for the payment. And document that the medication is not indicated at the current stage of the patient's disease trajectory. So make sure all this documentation is very easy to find. So where to do that can be challenging for where you're documenting your non-covered medication. I don't personally recommend the CTI narrative for that because the CTI is done once per benefit period. And as you know, patients' medications change regularly, much more often than once every benefit period. One option is the IDG note, and that this can be documented either by the physician in the IDG summary or the nurse case manager can document the results of the discussion with the physician in the IDG summary. Agencies might decide to have a specific form that they want to document this on, but the reasons for not covering the medications needs to be very clear and easy to find. So another challenge is, like I had mentioned, ensuring that Medicare Part D is not going to be paying for these medications that are determined to not be covered under the hospice Medicare benefit. So notifying the pharmacy that the patient uses, including the facility pharmacies, is essential to closing that loop. Often, what I've seen is that we do send over to the nursing home pharmacies a list of covered and non-covered medications, but included in that is not if they should be Part D covered or not. So that might be something to consider adding to your notification of your patient's facility pharmacies, as well as their pharmacy of choice in the community for patients who do not live at a facility. Also, make sure that you get that ABN to protect your organization to show that you had the discussion with them and that it is the patient's responsibility to pay, because when that audit comes back later and somehow it slipped through and MedD paid for it, you need to show that you did due diligence to make sure that this did not happen. Pharmacies don't always check to see if a patient is a hospice beneficiary prior to facilitate filling a prescription. And make sure, I know we do this on admission, I know we do it all the time as hospice providers. I don't know how we can possibly do it more, but this is a recommendation by Medicare, is to make sure that the patient and caregiver know how to coordinate all care and services through the hospice. And what's funny is when I look at the OIG reports, reasons for not providing drugs, this incorrect medication payment, is still the top ones are that hospice had no idea that this medication was prescribed and filled by an outside pharmacy, or that the nursing home staff got the order and sent it to their pharmacy. No matter how many times we tell people, this continues to happen. No matter how many stickers we put on nursing home charts back in the old days, or books we have out there, or as much reminder that this patient is on hospice, somehow we come in for our next visit and there's all these things that were ordered that we had no knowledge of. Um, the hospice miscoded the drug as non-covered, completely reasonable. People make mistakes. That does happen. The drug was dispensed close to the hospice admission, so the NOE wasn't even processed. Absolutely can happen, for the first couple days or even the day of admission. The pharmacy put it in as they knew that the patient was on hospice, that they made a mistake. Yep, that happens too. And the hospice thought a third party was paying, or they would have covered the prescription. And I looked at that for a bit and tried to figure if that had ever happened to me. And I don't think it has, but I have had patients who are on hospice under the Medicare hospice benefit, and they also received some services through the VA benefit, where I could have assumed that the patient was getting that from the VA and didn't really know for sure that they weren't getting it under Part D. So I can see how that all of these can happen, and especially the top two, I can see happening all the time. So for DME treatments and supplies, this is pretty much just like the medications. So CMS requires that the DME treatments and supplies related to the terminal prognosis and symptom management are covered by hospice. So unrelatedness is challenging to prove for these items because in the Chapter 9 Medicare Policy Manual, it specifically says things like all DME and supplies related to patient comfort and palliation of symptoms would be something that is covered and should be on the plan of care. So DME and supplies, it's really hard to figure out how to not have those be related. But also look at treatments and for things like a patient fall. So looking a patient who falls, is it a mechanical fall? Did they trip on something? I had a patient once who was on hospice for um, bradyarrhythmias, and he had syncopal episodes and would fall down prior to coming on hospice and on hospice all the time. So his falls were definitely related to his terminal prognosis and the diseases causing that. However, one time he fell and broke his arm, and he was dancing with his great grandson on bubble wrap and was witnessed by his entire family slipping on bubble wrap and falling and breaking his arm. That is a mechanical fall that actually had nothing to do with his terminal prognosis, because we were able to literally show that. But he did not lose consciousness. He had no syncopal episodes. So, but more often than not, the weakness from the decline is going to be what causes your patients to fall. So treatments for injuries related to the fall can be responsibility of hospice. I remember back a long time ago, we would have someone go to the emergency room for the CT. They were at a facility and maybe that was their protocol on witness falls, get a CT to make sure there's no brain bleed and then send them back. And we used to say it was unrelated, but Medicare is looking at that differently now because the fall is likely hard to prove that it's not related to the decline in status. So that would be the emergency room trip, the ambulance ride, all of the things involved in that. So, organizational processes to manage all of this. What are the things that you have in place at your agency to make sure that we're determining this and documenting it? Most organizations don't currently have a specific process. They might have some process at IDG of the doctor reviewing the diagnosis list periodically, but on an ongoing basis, reviewing all of these items to stay timely so we can meet that 72-hour deadline or 3-day deadline after the patient's been admitted to be able to get them their election statement addendum. Also looking back at your patients who were on before and making sure you'll be able to manage your RAC and ZPIC audits. Hopefully you never get one, but being able to manage it if you can. So developing a process at admission to audit all diagnoses, medications, treatments, and supplies for related diagnoses would be great. It would be a great QAPI goal, actually, is to look at that and see, work on improving that and getting that timely and to 100% would be something you could absolutely use with your QAPI. And double checking also in your QAPI project is making sure that there's consistent documentation. Is the medication and treatment coverages matching the diagnosis relatedness that's listed? Is it matching the CTI narrative? Are all of these things saying, because OIG caught a lot of those in their audits of showing that things weren't consistent throughout the chart. And then developing a process for all new diagnoses, medications, treatments, DMEs, and supplies to be appropriately documented as related or unrelated throughout the care. So all of diagnoses, medications, treatments, DME, and supplies as part of the patient's plan of care need to be changed on a physician's order. So perhaps finding something when new orders come in to be able to do an audit of looking at the new orders to make sure that any relatedness has been documented appropriately. And also looking at your physician, your hospice physician or hospice medical director, does he need more training or she need more training? A lot of the physicians are not skilled at determining relatedness, and definitely your attending physicians who are not hospice physicians are not going to be very skilled at documenting this. So, looking at what training they might need to be able to make this determination would be important. And I know the American Academy of Hospice and Palliative Medicine has trainings, NHPCO has trainings, as well as this one here that we're doing. But getting the information to your physician so we can make sure that this is done accurately. So, what's your process for documenting unrelatedness? So, the Federal Register says that we need to document relevant clinical practice, policy, or coverage guidelines to be citing those for why identified conditions, items, services, and drugs are unrelated. So, documenting using these terms here is going to be helpful for your hospice physician. So, documenting that it's not effective and why it's not effective, documenting that these medications or treatment are not supported by the evidence at late stage illness, documenting harm, the risk versus benefit, because the patients and families often do not see medications they've been taking for the last 10 to 30 years as potentially being harmful, but at this stage in the illness, they are. Documenting that you're following your policy about following your hospice formulary and that they are being offered alternatives and declining to accept the alternatives, and also documenting palliative versus curative. So in the election requirements by Medicare, it says that they are to have in your election statements that they understand that they are doing palliative and not curative treatments. So looking at these treatments that someone might be on and what is the goal of the treatment and documenting the goal of the treatment. Be careful with palliative radiation and chemotherapy because the OIG and CMS have specifically mentioned those, is that not all radiation and chemotherapy is curative. Some of it is palliative, so make sure that you really get the goals documented appropriately. And your IDG documentation, making sure every member of the team is documenting that the patients and families understand that hospice approval is required, making sure your clinicians are documenting in the plan of care as to the covered items, and not uncovered. Like if the physician is saying this mental illness is not related, but your social worker is documenting about their anxiety and bipolar disorder, that's going to be problematic. Looking at, do your nurses feel confident in having the deprescribing conversations, and of course making sure that's documented, and documenting communication with the patient, family, and attending physician, if any, about medication and treatments that are determined to be unrelated and potentially harmful. Having a hospice physician to attending physician conversation can be necessary here because sometimes the attending physicians just do not get these palliative principles, but consistency in documenting across the IDG is absolutely key. So, in summary, today we reviewed the history of Medicare spending outside the hospice benefit and why this is now under a lot of scrutiny. We looked over documenting and determining diagnosis relatedness and unrelatedness. We discussed how to determine and document medication and treatment relatedness and unrelatedness, and discussed some ideas for organizational processes to manage the regulatory scrutiny, both CMS as well as your potential ZPIC and RAC audits. And when you guys, if you care to check any of these references on here later, as you can see, it's a lot of Federal Register and OIG, but straight from the horse's mouth. So thank you very much, Jim. Back to you.
Thank you so much, Carol, for your insights. We now have a few minutes left for question and answers. Again, listeners can submit questions using the GoToWebinar app. So our first question, if a patient is admitted with a diagnosis of lung cancer, but has a history of ESRD and is on HD, would you say the HD is related and the hospice should pay?
I knew this was going to be the one that comes up because the hemodialysis and ESRD is such a challenge because is when we go back to the difference between causality and related to the prognosis. And so that's where CMS is looking at that. And they specifically mention renal disease as a significant comorbidity that impacts patients' prognosis. So it is one of those about 10 diagnoses listed that pretty much impacts everyone's prognosis if they have it. So historically, we would say that it's not related to their lung cancer. It's a completely separate system. It's a completely separate physiology. However, it's very hard to document. And so if your physician can find a way to document that the patient's end stage renal disease is not in any way affecting and impacting the patient's terminal prognosis of 6 months or less, then that will work. But that's going to be a really tricky one to cover. And I recognize, and CMS has recognized in some of their releases, that the rules in place about this do significantly impact the ability for patients with end-stage renal disease to access hospice Medicare benefit in a timely manner, because it is, in order to qualify for ESRD, you have to go off of the dialysis. And now that there's so much emphasis on related to the prognosis and not related necessarily to the diagnosis, it makes it challenging for hospices as well. But it's also challenging to say that if you are having this comorbidity of renal disease, that most patients on dialysis are symptomatic. They feel terrible often before and after dialysis, and will be care planning that they feel ill and the side effects of the treatment. If you're care planning that, then it's also very challenging to say that it's not related and shouldn't be covered. So if your hospice physician can find a way to do that, then I would love you to share it with everyone because it's definitely a challenge. I agree.
Thank you. And another question that came in is, how do we coordinate drug changes for mental health issues when the HMD is not comfortable doing this?
I have worked over the years with a lot of patients with serious mental illness, schizophrenia, schizoaffective, and it's definitely a challenge in that hospice medical directors don't feel comfortable prescribing psychiatric medications for SMIs, and psychiatrists do not want to see the hospice patients because they feel like they're not going to get covered. I used to tell them, use the GW modifier on your bill and you're going to get paid. But since Medicare is specifically stating that these mental illnesses are in fact related, that also becomes challenging. My recommendation, if you are able, is to have a consultant psychiatrist or a psychiatric nurse practitioner who is comfortable to consult for you either in person or be able to do phone consults. You can also discuss with your pharmacy consult to be able to see what types of medications. But I agree, I've had challenges working with the SMI and that no one wants to prescribe for these people. And unfortunately, what winds up happening when no one will prescribe is that the patient suffers not only from their physical illness, but their mental illness becomes more challenging and adds to their symptom burden. So my recommendation has been to find a psychiatrist who you can contract with or a psychiatric NP to be able to give you a consult. And if that's not something you can do, checking with a pharmacist or pharmacy benefit manager, pharmacist consult.
Thank you, Carol. And we're going to try and squeeze in one more. Would items, services, or drugs that are life prolonging in nature be uncovered?
I would love more clarification as to which ones, because I mean, if you look at, say, a cardiac disease, a lot of the medications we use for comfort also potentially are the medications we use to treat. So taking them off of those medications increases their symptom burden. If it's considered curative versus palliative, for some treatments it's hard to draw that line. You can also refer to your LCDs and see about that. For example, like an ALS patient, it specifically states that they aren't taking tube feedings or they're not on ventilators or invasive ventilators as part of the criteria to be on hospice. However, we will sometimes admit those patients with those as well for their greater benefit. So trying to build those things that are related to their symptom, to their primary diagnosis and all of the comorbidities. If you're going to take the patient on those, CMS again is saying that they're considering pretty much everything is interrelated, and you have to prove through either policy or through relevant clinical practice that this is not something that is appropriate at this patient's stage of illness. And again, not charge it to Medicare Part D. At that point, it would need to be the patient and family's financial responsibility. And that's where the challenge is if they really want it and it's considered life prolonging, don't charge Medicare D for it, or that's where you're going to get the challenge. Make sure the patient and family are covering that treatment.
Thank you, Carol. And we're just about out of time. Apologies if we weren't able to get to your question. This concludes our webinar. Carol, thanks so much for your presentation, and thanks to everyone else who joined us today. And, please take care.
Thank you, Jim. Thank you, everyone.